I got 2 pieces of advice before coming up here. My daughter told me not to flap my arms and act like a bird. And Efrat told me to speak slowly. One of those things I may be able to follow. I'm not sure which one. I work at the MDA ALS Center of Hope at Drexel University, which is in Philadelphia, Pennsylvania. I'm the physical therapist and the assistive technology professional there. Julie Moravec is my biomedical engineering student and my research associate, and she really helped me with the work today. And my good friend and colleague, Peggy Allred from Cedars-Sinai in Los Angeles, she's been working with me for probably a year and a half. We've been talking about equipment and what we want to do with equipment, how we want to work on this, what can we come up with as a study, because we think it's so important. We think that equipment use really can make a difference in the lives of people with ALS MND, which is pretty obvious, as well as we think multidisciplinary teams are one of the best places for people to get equipment. That being said, we know that the timing of when equipment is recommended varies depending on who the therapist is or where they go. We know that in the United States especially, and then we heard also with other countries with augmentative communication devices, that there's really limited ability for people to get that and get it paid for, and that's a huge issue. So we thought that establishing trends and timelines based on somebody's progression in their disease would be really helpful to people. Not only helpful to us, helpful when we're trying to get equipment paid for, but also helpful to patients and their families when they're trying to kind of map out their life and where things might fall. So we went to investigate what type of equipment is being used, when is it being used, and then hopefully develop an algorithm from that. So basically we're looking at when can we get the right equipment to the right people at the right time. We got IRB approval at both Drexel and Cedars-Sinai to do a retrospective chart review. We looked at 100 charts of deceased patients because we wanted to look at the entire time frame of their disease duration. The range was 1 visit up to 36 visits, and they tend to come in every 3 to 4 months. We collected different disease parameters and equipment data. We looked at the disease duration from symptom onset as well as from the diagnosis, the ALSFRS, vital capacity, lower extremity strength, balance, and falls. In case you're not aware, we use the ALSFRS score a lot in studies, so Peggy and I and a lot of people I know are very familiar with it, but in case you're not, I just want to mention it because it's going to come up a few times. It's a functional rating scale. It's somewhat subjective, and it's a total of 48, and we were, in some instances, specifically looking at what they consider the gross motor, which is turning in bed, ambulation, and stair climbing. We also looked at equipment. We looked at what type of equipment when it was first mentioned, so that first time that it was either recommended or used, that it was documented in their charts. And of those 100 charts, 60 were male, 40 were female. The average age was 63 years. There's 71 limb onset, 29 bulbar onset, and the majority of them were Caucasian. From symptom onset to diagnosis was an average of 16 months. From symptom onset to death was 2.66 years, and duration of disease from diagnosis was 1.35. Of these charts, this may not be shocking to any of you, 100 people used equipment. Of all the charts, everyone was using some kind of equipment. This is just the PT-related equipment there. This RADA, I'm not going to discuss every single one of these, don't worry. What we're going to discuss today then, because we had to narrow it down, is specifically the ankle-foot orthotics, ambulatory aids, and wheelchairs. And when we're talking about the braces, I'm talking about any kind of brace. It didn't matter if it was a double upright, a carbon composite, a posterior leaf splint. The first time it was either recommended or used, we collected that data. And just to tell you a little bit about what these charts are going to say, 28 charts, we noted that we recommended it. And then in 28 charts, we noted that it was being used. That doesn't necessarily mean it was the same person. We were looking at each visit date separately. Does that make sense? So we captured that point in time. So the ALSFRS average, which I think is interesting here, was that it was actually slightly higher when people were using the AFO. The strength was a little bit lower, and falls were about the same, and the time from when it was used was actually a little bit shorter than when we were recommending it. And it was a little bit earlier in the disease duration. Ambulatory aids, again, any kind of ambulatory aid, anything from a cane up to a rollator. Ambulatory aid was the most frequently used item out of the 100 charts. 74 people were using some kind of ambulatory aid. The ALSFRS average, again, was slightly higher for people who were using the aids than when we recommended them. And then we broke that separately in the cane and walker because we thought that was an interesting finding. The strength, again, is a little bit lower for when people are using it. Falls is about the same. And the months from onset is about the same. But again, the disease duration, people were using ambulatory aids a little bit sooner in their disease duration. Manual wheelchairs, whether they were transport kind of chairs or a full-on reclining chair or tilt in space. 25 recommended versus 44 used. Average ALSFRS is finally trending in the direction that we anticipated, where the people who were using the manual wheelchairs were a little lower. Then we pulled out that ALSFRS score for the ambulation. 2 is when you're using an ambulatory aid. And so the people you require assistance for ambulation. And so most people using a manual wheelchair hit that point. And the strength was a little bit lower. And falls documentation was very high for when we recommended the manual wheelchair use. The forced vital capacity was a little higher for people when we recommended than when they were used. And about the same time frame, we were both recommending and using wheelchairs. Power wheelchairs, and then the other point for power wheelchairs, not only just what kind it was, but also whether it was purchased or rented or borrowed. It didn't really matter, just if they were using a power wheelchair. So we had 48 people that we recommended and 33 that we noted the first time use. The ALSFRS score average was higher when we recommended than when it was used. Now you start to see that ALSFRS score fall below being able to ambulate. So it's below that 2 point. And falls documentation, 50% of the people, we were documenting that they had fallen at that visit when we recommended a power wheelchair, but only 21% when they came in and said they were using a wheelchair. Forced vital capacity is going down a little bit, and 2 of the people using power wheelchairs also used tracheostomy ventilation. And the month from onset is getting a little bit further out now. So now we're looking at, we recommend power wheelchairs at 58% of the disease duration, but they're using them about 70%. And if you remember, which you probably don't, but I can flip back, where people are saying that they're using the manual wheelchairs at 58% of the disease progression, which is at the same time then that we're recommending power wheelchairs. So when you look at this data, I mean, those were a lot of charts, and you can look back through them again later. As a therapist, I can picture all these people, and this is one of the points that we were trying to pull out, is when I look at this description of this person where their ALSFRS is dropping and their leg strength is just fair or good minus, and they're falling and their vital capacity is dropping, I can picture that person. So Peggy and I felt like none of these snapshots in time were out of the ordinary. They fit into what we felt would be a nice picture of what the person looked like. So we wanted to go on then and look at pull out some of the different pieces and look at some of the different of the disease parameters that we were looking at. When we looked at the ALSFRS average, and I had mentioned this earlier, when people were getting the AFO, the canes, the walkers, their ambulatory aids, when we were recommending them, they actually had a lower ALSFRS score than when we were recording that people were actually using them, which was unusual. We were surprised by that. We're not really sure why that happened. We don't know, because the ALSFRS score is a little bit subjective. Is it because they were perhaps scored themselves higher because they felt like they could do more? Are people more willing sometimes to go and get them on their own? Are there certain people who would start them earlier? But it was an interesting piece to pull out, and we want to look at that more. The wheelchair use was much more what we expected, where people were using them at a lower ALSFRS score. And then the other piece was that across the board, at 35, a score of 35 out of 48 is when people were starting to use the assistive devices. So what that would mean to us is, if you're being seen at a clinic perhaps where you're triaging, where the therapist isn't seeing everyone, or if you're a therapist who's out there and you're seeing someone and you're not part of a clinic, that once somebody's ALSFRS score drops below a 35, that is when we would say, you should probably have them see a physical therapist. That should trigger a referral to a physical therapist, the ALSFRS dropping below a 35. And then strength. I couldn't pull out everything because some of ours fell in between. So in therapy, a lot of times if it's a 5, or it's on a 0 to 5 scale, we'll say 3 to 3 plus or something. So it's a little bit on average here, but there were some interesting findings in the strength as well. The lower extremity strength on average is higher when we're recommending the manual wheelchairs than when we're recommending ambulatory aids, which was not what we expected again. But it is lower when people are saying that they're using a manual wheelchair. So we're recommending ambulatory aids, it seems, almost further into the disease progression. So one of the things we want to do is pull out some of the different ambulatory aids and see if that doesn't give us some different information. We also found that AFO use and recommendation was more targeted towards dorsiflexion weakness versus with wheelchairs, it was more like overall generalized weakness and falls. And then falls was also quite interesting in that it was very high. 80% of the people had told us at that visit that they had fallen in the time that we recommended manual wheelchairs. So falls are reduced with wheeled mobility, and manual wheelchair use correlates with the power wheelchair recommendations, which I talked about before. So what we're recommending is, well, first of all, we need a standardized flow sheets of equipment recommendations, because we found even whether we were using paper charts or electronic charts, we weren't pulling out all the information. Falls weren't documented every time. Things just weren't documented every time. I already said that lower than 35, manual wheelchair, we already recommended these, so we can move. So the last thing I just wanted to talk about was the considerations for the future. My concern was these one-time visits. So we had 11 people who were only seen one time. That could be that they came in for a diaphragmatic pacer evaluation, they came in for a drug trial study, they came for a second opinion. We don't know exactly why they only came for one visit, but we feel like that they're not really giving us the data that we need. We need more of the longitudinal studies. We also need to exclude other neurological diseases. So if somebody had post-polio or somebody had a stroke and they were using a device because of that, we need to take them out. Also, death from other causes. If they had a car accident or if they committed suicide, we need to take their data out. And we really need to focus on the longitudinal data. This can be expanded to other disciplines, so speech therapists can also look at this and pull out their data. Occupational therapists can also look at this and pull out their data. It's really not a difficult way to look. It's time-consuming, but it's not difficult. And it, of course, can be applied to other countries. So even though this was, we looking at our clinic setting, it can be used anywhere. Some of the things we want to look at for longitudinal data, this is just an example of why we want to look at it. So where we recommend, and then where do they get it? Where is that disease progression? These are the people I want to acknowledge. There was a lot of time and effort and work put into going through all these charts, and 2 additional references in case anyone wants to read more about durable medical equipment. And any questions?
Can I just say first, as a person who runs a comprehensive equipment supply activity, being able to have a timeline against which we can plan not only delivery but acquisition is really helpful. And,
right. And I think that's one of the reasons why we really need to look at it longitudinally. We need to take out those one-time charts, one-time visit charts, and be able to, that's our next step. We know we have a lot more work to do with this, but so far we're finding some really interesting
questions.
Things.
Come on, I know it's last session. Over there, and then here.
First. Okay.
Ask at the same time.
Hi, I'm Malavika Ghosh from Preston, UK. Really interesting. I'm not quite sure, and I'm, in the UK, occupational therapists do a lot of equipment provision. And that's why I had to ask you this question. When you mention about wheelchair provision, do you follow a criteria for providing the wheelchairs? And at what point would you normally provide a wheelchair to the patient?
We do not follow any specific criteria. It's just based on our evaluation and asking them when, as we're doing our evaluation and just finding out what their needs are. But in the United States, if you are ambulatory, functionally ambulatory outside of your home and even inside your home, the insurance won't pay for it. So we're trying to take that piece out and just say when we are recommending, because then you can sometimes get it through loan closets or by other means.
Right.
Yeah.
Well, the reason I'm asking...
Sorry, we'll have to move on to the next question.
Okay.
Sorry.
Amber Ward from North Carolina in the USA. I have a little trouble with the 35 out of 48 for the ALSFRS, simply because you can have, handwriting and bulbar and those sort of things making up your 35 out of 40.
Right.
And I'm wondering if maybe the guidelines don't need to be just those 3 motor scores as sort of a percentage of those, of that amount of score instead of the entire ALSFRS. What do you think about that?
Well, we were concerned because once you just look at let's say the mobility related, and you're scoring, once you start scoring ambulation, you're marking it down already. So we were trying to look at it more globally. Does that make sense? Once you're using an assisted device, you're supposed to get a 2. So it's hard to break that out. Yeah, it's not sensitive enough. And it's not that we're saying it's definitely 35, but places that triage or places that don't have a therapist, that's a time where you don't have, just trigger it. Just go ahead and recommend it.
One last quick one right up the back.
Can you hear me? Yes. Thank
Yes,
you, Sarah.
Albert.
Recommendation, the one side of the event, the other side is the accepting the physical equipment. Is there any data correlating between recommendation and accepting?
We haven't been able to look at that yet, but we do want to look, when we go back and only look at longitudinal charts, we actually plan on taking the 11 out that were one time and replacing them with 11 other ones, and then seeing, we should be able to pick up some reasons why people didn't get the equipment. There's, if we wrote it down, if it was documented.
Thank you.
Join with me in thanking Sarah.